discussion on operative. Today we'll have a operative surgery discussion on truncal vagotomy and gastrojejunostomy. We'll discuss both open and laparoscopic. Presentation will be by Dr. Sritama Rai, who is second year junior resident at Ruby General Hospital, and Professor Shudev Saha, who is professor of surgery and head at NLS Medical College, will moderate the session today. Sritama, we already discussed that this is the scenario. Let us go as by exam scenario. Dr. Shudev Saha can start. Okay.
Yes.
So in the exams, you have a table for operative surgery, right?
Yes, sir.
And the table usually has two parts. One, we ask something about emergency surgery, and in the second table, we ask about elective surgery. So vagotomy and gastrojejunostomy is usually an elective surgery. Limit ourselves to the operation itself. And to start with, you can say words regarding indications if you want to.
So, regarding indication?
Yes, indications.
Indications of this operation.
Okay, so truncal vagotomy and gastrojejunostomy is done for chronic peptic ulcer diseases and for patients who are having peptic ulcer disease related gastric outlet obstruction or pyloric obstruction.
No, which peptic ulcer disease? All patient does not require surgery. What are the indications of surgery in peptic ulcer disease? When you consider surgery?
Sir, when peptic ulcer disease chronically causes outlet obstruction, pyloric obstruction.
That is complication. That is a complication. Apart from complication, there are some indication when you consider for medical and surgery.
Sir, refractory to medications.
Yes, refractory failure of medical treatment.
Medical treatment, yes.
Then.
So a very small percentage of peptic ulcer disease nowadays we find have some problems and they are not amenable to medicines because previously when we were students, vagotomy gastrojejunostomy was a very routine on the OT list, right? So but nowadays is extremely most commonly is done as treatment for complications of it. So that thing should be first, not one which you said, right? So complications of peptic ulcer should be first. I mean, this is, broadly speaking, indications for surgery. Indications for surgery in peptic ulcer, number one, complications.
Yes, sir.
Right? Of course, you may not do so for the peptic operation. You will do only peptic operation. Okay. So in other cases, you have to do. So that should be first complication. Then you will move over to, in a very small number of cases, you may have to do it in refractory cases. Anything else?
Truncal vagotomy.
And gastrojejunostomy, yes. Any other indication? We sometimes have to do it. Yes, we sometimes have to do it in cases of muriatic acid ingestion, right? These cases do come to us where the upper part, that is the esophagus, has somehow been treated, right? So the patient swallow, there is no option installing. So what happens is this now is a gastric outlet obstruction. Okay, because due to that corrosive, which was ingested quite some time back, it gets accumulated in the stomach for a while, due to which it causes fibrosis out there and gives rise to outlet obstruction. Yes. So in such cases also you may have this operation. So please remember this indication also. Please proceed. So the patient is on the table.
Yes.
Right? Yes. Let us start with position anesthesia and so on and so forth.
Okay, patient is positioned in supine position and under general anesthesia. Parts are painted and draped. And in open surgery, we do a midline incision from the xiphoid process to the umbilicus. After that, we do exploration of the abdomen to see any related associated disease and if we can find the ulcer palpable. Next, we go on to assessing the abdominal portion of the esophagus. After finding the intra-abdominal esophagus, we go on to divide the triangular ligament of the liver. Uh, After then we retract the left lobe of the liver outward. After retraction, the lower part of the esophagus, that is about 5 centimeter of the esophagus, is visualized, and peritoneal layer, that is the phrenoesophageal membrane, that is overlying the esophagus, is dissected. Then we go on to identify the anterior vagus nerve, which is the left vagus nerve, and that is dissected. For doing this, we have to retract the stomach on the downward and outward.
How do you identify it? How
Sorry,
how do you identify the left or the anterior vagus?
So after dividing the phrenoesophageal membrane, we can find it on the anterior portion of the esophagus. It basically comes from the left side. So we have to retract the stomach to the
Yes.
downward and outward, and
Yes,
then
on retraction, it stand out as a cord.
yes, as a cord.
Yes, you have to hold the body, the stomach with your left hand and
Yes.
pull it downwards and laterally. And
Lateral.
then when you feel with your right index, you can feel a string-like thing which at the gastroesophageal junction just below the peritoneum, prior to peritoneum, visceral peritoneum, right? So that is how you can identify the left vagus. It is usually to the left of the midpoint at the gastroesophageal junction. If there is a midpoint, just to the left of that.
Yes.
Okay. Yes. Then what you do? We actually will try and expose the lower part of the esophagus, and the truncal vagotomy is best done on the esophagus itself. Yes. Carry on.
So we have to dissect the anterior vagus with using right angle forceps, and after that we have to clamp it using hemostatic clamps, and we clamp it on both sides with 1 centimeter in between, and we cut the 1 centimeter margin, and on both sides we ligate it with silk. After the anterior vagus nerve is ligated, we go on to find the
the idea is, hold on. The idea is you have to remove a portion of the nerve, right?
Yes, remove a portion.
Just ligating and dividing is not enough. You have to remove a small portion of the nerve so that, yes, okay, that's fine. So you can submit it to histopathological examination and make sure that what you have removed is actually a nerve.
Is a nerve.
Okay.
So then we go on to divide the hepatogastric ligament through following which we enter the lesser sac of the stomach, and after this we have to delineate the after this we have to delineate the posterior vagus, which lies below, and for this also we have to dissect that. We have to find the posterior vagus in between the aorta posteriorly and the esophagus anteriorly. It should stay in the it will be found in the middle, and after finding the anterior vagus, we have to dissect it similarly, right angle forceps, and after that we clamp it on both sides with hemostatic clamps, and take out a portion of 1 centimeter of nerve from that. Sir, hello?
Yeah, you have told it simply, but it is not that easy, right? Finding the posterior vagus is slightly more difficult than finding the anterior vagus. Right? So I would like to know the exact location where you will find the posterior vagus. Can you tell me the exact location where you will find the posterior vagus?
Um,
The posterior vagus is formed. Listen, in the part where we are talking, you have two crusts, right? We have the left crust and we have the right crust. Okay,
and near the right
and
crust, sir.
the exact place where you will find the posterior vagus is opposed to the right crust.
Right crust,
Right,
right
it is
crust.
on the inner side of the right crust. So that is between the esophagus and the right crust. You have to search for the vagus. And
Yes.
remember, this posterior vagus is much thicker than the anterior vagus.
Yes.
So you will put in your right index there, and you will have to not only feel, you will also have to look and see. Because in our days, it was a blind procedure where we have to feel and pick it up. Nowadays, it is no longer a blind procedure,
Yes.
right? And if you can encircle the esophagus with a string, some kind of a string, either umbilical tape or you can use a catheter, and you can pull it to the left. And if you can hold the right vagus and pull it to the right, then that is where you will be able to see the right vagus. So I would suggest you see the right vagus, show it to your assistant, and then you lift it up with a right angle forceps.
Yes.
Okay, so that would be the best way to do it. It should no longer be a blind procedure. It should be it should be clearly visible. Right vagus is clearly visible before you can actually pick it up. Right here also the same thing. You will
Same
have
thing.
to remove a
Okay,
portion
the
of the vagus.
hemostatic clamps, and then portion of the nerve is removed, and then the both ends are tied with silk.
Yes, yes. Why do you need to tie both ends with silk?
Yes,
Tie
there are
it,
sometimes small blood vessels that are accompanying the nerve, so that is
not
why we have
sometimes, not sometimes, always.
always, always.
Yes,
Okay.
particularly on the right side.
In relation to the posterior vagus, there
Yes.
is a nerve branch called criminal nerve of Gracie.
Yes.
What is that?
Sir, small branches that that are branching out of the posterior vagus and to the portion of the fundus of the stomach, and we
Yes.
have to make sure that we are also taking them while we are dividing the posterior vagus.
Yeah, that means you have to go high up.
Higher
You
up,
have to
yes,
divide the
proximal.
vagus nerve posterior trunk quite high so that you
High.
take care of this criminal nerve. Otherwise, a patient might have this nerve being retained there.
Yes.
Okay, fine.
And these criminal nerves, they actually come to the left of the esophagus, right? So that is
Yes.
why they are very likely to be missed. They come from the left of the esophagus. Though they are coming from the posterior vagus, they are coming from the left of the esophagus. And you have to make a part of the esophagus bare in that part so that you can encircle, you can put your finger on all sides of the esophagus and make sure there are no other nerve branches out there.
Yes.
Okay, proceed.
Sir, so this is the procedure of the truncal vagotomy is done. Then we have to
Yes,
proceed.
after the truncal vagotomy is done, then
There is some ooze. How do you manage? There is some
yes,
ooze in this
yes,
area. While mobilizing,
yes,
there is some ooze in the area. How do you do? How do you manage? This was our practice. Once you do this, you put a
Sir,
sponge.
gauze,
Yes, you put a sponge. Mop.
compression. Yes.
This compression will control that bleed.
you put a mop out there so that after putting a mop there, you do with your rest of the operation. And after you finish the operation, make sure you remove that mop and see whether there is still any oozing out there. Okay, proceed.
And next we have to proceed for drainage procedure. So we go for a Roux-en-Y gastrojejunostomy. Could I?
Yes, you carry
Why
on.
do you want to do a Roux-en-Y gastrojejunostomy?
Sir, we also.
What are the other ways of doing it?
Sir, other way we can also do a loop gastrojejunostomy.
Yes.
But
Why would you do a Roux-en-Y?
You can defend the statement that Roux-en-Y gastrostomy because Roux-en-Y has some advantages over loop gastrostomy. What you pick up? You pick up a defunctioning loop of jejunum
Yes.
and do the anastomosis. If you do a loop, what is going to happen in the food material? There is chance of
reflux.
yes. So bile reflux is more. Bile reflux gastritis is more because the afferent loop is in the stomach,
Yes.
and chance of bile reflux gastritis is more if you do a loop gastrojejunostomy. So now the preference is more towards a Roux-en-Y. You have to defend your statement. Why do you said I'll do Roux-en-Y? So examiner asks and she has to defend. Roux-en-Y is better than a loop gastrojejunostomy because I take a defunctioning loop of jejunum of 35 centimeter. So the risk of reflux is not there at all.
Yes. Okay. So should I proceed?
Yes, sure.
Okay.
And what is the disadvantage of a Roux-en-Y gastrojejunostomy?
So yeah, we are doing two anastomosis, so chances of anastomotic leak and bleeding.
No. You're doing, you're doing yes, the number of anastomosis is more while you're doing a Roux-en-Y. One in the
Roux-en-Y
gastrostomy, one
only.
is the jejunal. That is okay, fine. No, here, in case of Roux-en-Y gastrostomy, the chances of a stomal ulcer is slightly higher than it is in a case of loop gastrostomy. Anyway, gastrojejunostomies are very rare these days when, in benign conditions, right? Nowadays,
Yes.
whenever there is gastrostomy, mostly it is in malignant conditions.
Malignant condition, yes,
Right?
causing gastric outlet
So
obstruction.
it is very rare. That is why we don't have real statistics now. But even then, in case of Roux-en-Y, stomal ulcerations are slightly more common than we have it in loop care. Okay, proceed.
So, sir, first we have to fashion the Roux loop, and for doing this, we have to take go to the from DJ flexion about 15 to 20 centimeter distal to DJ flexion. We take we do the dissection of the mesentery and ligate the blood vessel and making a small rent there. After that, we divide the jejunum, and after dividing the jejunum, we bring the distal limb of the jejunum uh, towards the stomach, and here we have to make a rent in that mesocolon about in the right side of the middle colic artery, where is the space of Riolan, which is the avascular space. After
Right or
making
left? Right of middle colic or
In
left of middle?
the book it is described as right, but I find most of the time I do it to the left.
We always
With
do
the
it.
book, the
Always
statement
do it on
is
the left.
in the right. I don't know how it comes up.
Yeah, we almost always do it on the left. Anyway, it's okay, fine.
Yeah, the space of Riolan. Yes, the statement is right.
Right.
The space of Riolan is the avascular area through which you make a rent.
After making the rent, we bring the distal end of the jejunum to the stomach, and we push the stomach with Babcock forceps towards the rent to bring the two ends closer. We
Actually,
make
while doing it, hold on. While doing it, we don't take the jejunal loop into the lesser side. We bring the stomach out into the greater
stomach
side.
out of the yes, push it
Yes.
out.
Through that gap in the mesocolon, we pull out the stomach into the greater side, and then we do the anastomosis. And either before or after the anastomosis, you have to make sure that you fix that mesocolic range to the stomach.
Yes.
Right? Yes, that is something we do. Okay. Now, it is customary to tell us what kind of gastrojejunostomy you will be doing. There are certain adjectives out there. What we have already said is that we are doing a retrocolic anastomosis.
Retrocolic
Because we have gone, yes. So in malignant cases, we would almost always consider doing it anticolic.
And isopericytic.
Yes, in benign cases, we would almost always consider it doing retrocolic. Okay, proceed.
Okay, so after this, we have to do a side-to-side anastomosis.
What is Sidama? What is closed anastomosis? What is open anastomosis?
So closed anastomosis is when we are using intestinal clamps on both ends, and we do not use the clamps to avoid any trauma to the intestinal wall.
Yeah, clamps
On
don't
also,
cause intestinal trauma. Anyway, yes, clamps don't cause intestinal trauma. That is why they are called occlusion clamps. They are not crushing clamps, isn't it? So yes, that is how you're correct when you said what is open and what is closed.
yes,
And the thing is, we would always prefer to do it open, right? Because in closed, actually, I mean, there is a problem that you will not know which wall you are picking up because the amount of gut available to you is small.
narrow,
So
yes.
at least in case of gastrojejunostomy, you open the stomach, make sure you empty the whatever contents in the stomach with a sucker and all that, and of course the patient is prepared in an elective operation. So you can almost always do it open without using occlusion clamp. Right. Even if there is some bleeding, you can take care of the bleeding before you do start anastomosis. Okay, continue.
Okay, after that, we have to do a side-to-side anastomosis with the stomach and the jejunum, and you make a incision of about 5 centimeter in both the walls, and then anastomose we using 30 PTS sutures.
What? Single layer, double layer?
Sir,
If you are doing double layer, you have to apply the cerebromuscular first and then do the jejunotomy and gastrotomy.
Open the lumen. Yes.
Okay, if you are saying
Now,
you are
which
trying to
one
do
would you
that in
prefer?
the single layer, then it's fine. What's your
Which one
practice?
would you prefer?
sir, I have only seen one laparoscopic technique.
Oh, then it is a stapler only.
Stapler, yes.
But you have to know both. Open also you have to know.
Yes, sir. Haven't seen yet.
Because if there is a problem with the stapler, you will have to do it with your hand, isn't it?
Yes.
So that is the
Yes.
first thing you have to know. Yes.
So hand-sewn
Okay.
hand-sewn technique, we can also
Describe a standard hand-sewn gastrojejunostomy. Go by standard. That means 2 layers. One is posterior cerebromuscular.
and one is through and through.
What material you use?
So
What material you use?
PDS polydiacylon.
Okay.
30 PDS.
Fine. Then posterior cerebromuscular. And then what?
Then sir, we have to do a through and through, posterior through and through.
And then?
Then we do a anterior through and through.
Yes.
And then an anterior cerebromuscular.
Yes.
Okay. So you said it is 5 centimeters. That is fine. Now I would like to know where did you plan the incision on the stomach? In which part of the stomach are you going to make the opening?
Sir,
we have gone into the posterior surface of the stomach. That is fine, right?
yes, sir.
So where will you make the opening, right? What will be the? I mean, will it be close to the lesser curvature? Will it be close to the greater curvature? Right? Will it be oblique? I mean,
So it can be
vertical,
transverse, or oblique, or 3 kinds, and can be there. So location.
Okay. Where will you place? Place the incision on the stomach, closer to the greater curvature or closer to the lesser curvature?
So,
we are doing it in a benign condition. Remember. So remember, it has to be dependent, right?
Dependent.
So for it to be dependent, it has to be placed closer to the greater curvature.
Greater curvature, yes.
Yes. Otherwise, it will not be dependent. And it has to be oblique. Oblique in a manner, because remember the greater curvature, the blood vessels are going transverse to the axis of the stomach.
Yes.
It should not be very close to the greater curvature.
Yes.
Okay. It should be, say, about 1 or 2 centimeters away from the greater curvature, and it should be fashioned in an oblique manner. Okay.
Yes,
yes. I mean, after you have done after you are, suppose now you are doing the anterior through and through, right? At this time, what special things are done? After doing about halfway, after you are halfway through the anterior through and through,
yes.
What is usually done is we pull out the rice tube in the stomach and pass it into the distal lumen of the jejunum.
To see, to check for luminal patency.
No. Luminal patency is always there because you're doing it open. It's open surgery and it's an open anastomosis.
Okay.
Luminescence, there is no doubt about it. Now we put the rice, we bring out the rice tube from the stomach and pass it through the
Pass it to
anastomosis into the distal jejunum. Yes,
yes. Yes.
right. Now, since the rice tube is already there, so you have passed it through the anastomosis and then you complete the rest of the anastomosis.
Okay.
Okay. Now, the idea is very simple. The idea is just that make sure that the anastomosis stoma remains patent, the stomal edema doesn't occlude it, right? And
Yes.
I mean, this rice tube actually acts as a stent. Whatever gastric juice and all that is there in the stomach, it will, just because there is a stent to the anastomosis, it will gradually pass it to the jejunum.
Jejunum.
Yes. Because you have to place a rice tube in the stomach in a gastrojejunostomy. So you might as well put the distal end into the jejunum.
Yes.
Okay. And
Can you
initially we'll
describe
start.
a open stapler anastomosis? What you use? How do you do it?
Sir, you use a green stapler
What?
normally.
Stapler or cutter? For gastrojejunostomy, you are firing in the stomach and the jejunum. Blue is good enough. For transiting stomach, you use green.
Yes.
For doing a GJ, a blue stapler is adequate. So how do you do that? How do you do a staple anastomosis? There are few steps for that.
We make a rent in the stomach.
No, you cannot make a rent. There are something to be done. You bring the jejunum up close to the stomach. Then what
Yes.
need to do? You need to apply few stay sutures.
Stay sutures.
Where?
Yeah.
You need to apply 3 stay sutures. One at the distal end at the proposed site of anastomosis, and 2 more stay sutures in between which will make the gastrotomy and the jejunotomy. Okay, because these are required to steady the stomach and jejunum while you fire the stapler. Okay.
Yes.
So through the gastrotomy and jejunotomy, you insert the stapler and be in the cutting house and close the stapler and fire it. And then what do you do?
So
After firing?
After firing, after the gastrojejunostomy done, we have to close the open.
It's not over. Once you fire, something else needs to be done.
We have to wait for 30 seconds.
If you fire a stapler, is the procedure complete or something more needs to be done? That is done even in laparoscopy also. Even in laparoscopy, fire the stapler, some job is left.
You have to make sure that the staple line is free of any bleeding.
And the jejunotomy and gastrotomy you made, it will be open. You see, some part of this area is still open.
And because we have to close that.
Yes, you have to close that. You have to close that either in single layer or in double layer. Okay.
Yes.
So you need to close the remaining gastrotomy, jejunotomy has to be closed. Okay.
So then we have to, after gastrojejunostomy, we have to do the jejunostomy.
Yes. How many layers?
So we can do a single layer.
We can do I'll do it single layer.
I will do it single layer.
Yes. What? End to side or side to side?
Sir, we can do end to side. We will do end to side using 20 PTS sutures.
Yes. 30 is good enough. 30.
And sir, after this, we have to close the rent in the mesocolon, and we have to close the
mesentery, not mesocolon. Mesocolon, yes, mesocolon is the stomach, and then
we have to close the distal and the proximal end of the mesentery in the jejunum.
Yeah.
And sir, that's.
What are the complications of this operation?
So primarily we have to think about stromal ulcer, anastomotic leaks.
Doesn't come in the immediate postcard, right? To understand.
Bleeding.
You have been asked complication. You say so immediate
and late complication.
Yes.
Yes, yes. Whenever you ask in the examination, make it separate. Immediate complications, late complications, and you can also say, I mean, there's certain complications specific to this procedure, and there are other general complications which are common to all surgeries. So you can proceed this way. Okay.
Immediate complications are bleeding and anastomotic leak. Late and what else?
Now, bleeding actually occurs most commonly within the lumen, right? Not outside. So, I mean, that is why you need to make sure that while because you are anastomosing an organ which is highly vascular. Stomach is a highly vascular organ. So you make sure you take care of bleeding while you're performing the anastomosis. And in case you're doing it laparoscopically, or I mean you're using staplers, either laparoscopic or open, you have to inspect the suture line. And in case there are bleeding, you make sure you take another few bites out there. Don't use diathermy while you have stapled, while you have done a stapled anastomosis. So you make sure you go inside and have a look. And in case there are some bleeding, you take some figure-of-8 sutures out there, and that will control the bleeding. Okay. Normally, we don't use a drain, right? In a gastrojejunostomy, normally nobody uses a drain because these anastomosis, I mean, this anastomosis it is very extremely rare for this anastomosis.
Chance of leaking, yes.
It's highly vascular, both stomach and jejunum, and so leak is almost unheard of, right? And while you are picking up a jejunal loop, you have to be very careful. Because in the literature, there are a number of cases where an IVM was picked up, and it was gastroileostomy done by mistake. So you have to be very careful when you pick up the loop. Make sure it is the jejunum, and also make sure that when you are doing a Roux-en-Y, you have to make sure that you're picking up the distal loop for a gastrojejunostomy, and not the proximal loop. So these mistakes can happen when you are doing a Roux-en-Y. And lastly, you may land up with a colic fistula. When there is a stomal ulcer, it may somehow get into the colon, and they are extremely rare. So normally, well-performed gastrojejunostomy should not have any complications, right?
Yes.
Okay.
One important complication is prolonged gastric ileus in the post-op period. How do you manage? The other patient who may have prolonged gastric stasis and keep on sucking, there will be a lot of right secretion coming up. What is the management for that?
Sir, if prolonged gastric stasis, we have to manage the nutrition of the patient. So for that, we have to do a enteric, either nasojejunal bypass or feeding jejunostomy needs to be done for correction of nutrition status.
Feeding jejunostomy is an invasive procedure. You don't decide immediately that will be feeding jejunostomy. There are some steps for going with the gastric ileus. One is, you say, you can wait. You keep on sucking, replace the fluid electrolyte, ensure that fluid electrolyte balance is correct. And then, can you name some drugs which can help in return of this gastric peristalsis?
So prokinetic drugs like lesuride.
Yes, they are the newer prokinetic drugs. Earlier we used to use, and still people use, is erythromycin.
Erythromycin. Okay. Yes. Yes.
So feeding jejunostomy is an invasive procedure. You do not jump to an invasive procedure. You try all this because sometimes this vagotomy, this can go on for about 10-15 days even.
Yes.
A few words about late complications.
So late complications can be so one is atrophic gastritis can occur.
The most important late complication is stomal ulcer, recurrent ulcer.
Yes.
There are a number of late complications you have to talk about. Yes, one, as Mafamda said, stomal ulceration is there. There are something called dumping syndrome, right? This post-vagotomy diarrhea. So these things you have to mention, right? And what about gallstones?
Sorry, sir?
Gallstones. Is there
Oh,
any
sir,
risk of gallstone?
we are doing a truncal vagotomy, so there's a high chance of gallstone formation because.
Why?
Why?
Sir, because we are also denervating the nerves, the vagus branches that are supplying the gallbladder.
So there is
So there is
stasis.
chance of stasis.
Stasis,
Huh?
bile stasis.
What is dumping syndrome? I mean, what gets dumped where?
This can be early or late dumping. What happens in dumping syndrome?
Uh,
What happens in early dumping?
It can also occur, when you're doing any other drainage procedure with vagotomy. For example, you're doing a pyloroplasty. Even then, you can have a dumping syndrome.
So, because we are doing a gastrojejunal anastomosis, food directly gets dumped from the stomach into the small, like in the jejunum.
So what happens? It may go quickly to the distal limb. So what happens following this passage?
So there is a lesser absorption of food and less absorption of nutrients and
What happens? These are the patients who may have associated hypoglycemia. Why?
Hypoglycemia, yes, because the food is not getting absorbed.
No.
No. You give me a fundamental question. I mean, answer to this. Why dumping occurs in the first place? Because you have done a vagotomy, truncal vagotomy, and that has denervated the stomach also. So the stomach also is not supposed to have any peristalsis. So how will the food suddenly get dumped out there? Because I mean, it also denervates the stomach, isn't it? Primarily, why dumping? Is it a complication of gastrojejunostomy or a complication of vagotomy? Which one?
So it's a complication of vagotomy.
It's a complication of vagotomy. Yes. Why it occurs? Why does food get dumped into the duodenum or jejunum? I mean, because stomach also does not have peristalsis, isn't it? Let me tell you a few words.
Because the stomach, so the small intestine is functioning, releases gut hormones.
Now you see the primary function of the stomach when one is taking food is to relax.
Relaxes.
The stomach relaxes, so that is why it becomes a capacity vessel, and that it takes food within it, right? And when the food comes out into the pylorus, it comes out in very small quantities. The chyme is delivered into the duodenum in very small quantities. Now this property of stomach is lost when you have done a vagotomy. The stomach fails to relax. Whatever it comes into the stomach is immediately transferred into the
jejunum,
either into the duodenum or into the jejunum, depending on what drainage operation you have done. So this is the basic thing that goes wrong while you have done a vagotomy. Okay. Now what happens is that as Makunda was talking about hypoglycemia, as soon as the food reaches the upper jejunum, that is why they say that you have to have carbohydrate low diet. Right, yes. This gets absorbed and a lot of insulin gets secreted before the whole of the food can go down.
Yes,
So this
altogether the insulin.
Yes, this gives rise to hypoglycemia. There is some post-vagotomy diarrhea also. Right?
Yes.
That is in certain cases very difficult to control because there is not much you can do about it. Anyway, one more question: How will you treat dumping?
Sir, dumping. If dumping syndrome occurs, we have to give some precautions to the patient about low carb intake and small meals. And
small meals, low carbohydrate diet,
and complex carbohydrate diet should be done instead of simple carb, and increasing fat and protein quantity.
Yes. And what happened is that previously it was found that this is most common when you are doing a loop gastrojejunostomy.
Okay.
In certain cases, you may have to convert this loop into a Roux-en-Y gastrojejunostomy.
Okay, sir.
Right. That is why nowadays people also prefer, another reason why you will prefer a Roux-en-Y gastrojejunostomy over a loop gastrojejunostomy. Okay.
Okay, sir.
Anything else, Mahmoud? Mahmoud, anything else?
Okay, we have covered.
More or less. Maybe a few things here and there we must have missed, but otherwise I think we have covered.
Sitama, we have done a truncal vagotomy. What are the other forms of vagotomy?
So we can do selective and highly selective vagotomy.
What is the advantage?
Sir, if we do highly selective vagotomy, we are only hello, sir.
What do you cut in highly selective vagotomy?
Yes, sir. We are only denervating the nerves that are like distributing to the pyloric to the parietal cells of the stomach, and we are we are protecting the nerves of lateral jet in the distal part of the stomach that are controlling the motor functions of the pylorus.
So will you preserve the crow's feet, or you will divide the crow's feet?
The crow's feet. Crow's feet. So the nerves of lateral jet that has to be protected, sir.
Yeah, obviously the nerves of lateral jet is, it goes down.
Yeah.
But there are some branches from the nerves of lateral jet which supply the distal part of the stomach, which is referred to as the crow's feet, both anterior and posterior.
Yeah.
So they are supplying the pyloroduodenal junction.
Yes.
So that is the part which has to be preserved.
Preserved.
Otherwise, you will have to do a
drainage.
Okay.
Okay. Thank you, Dr. Shah. Thank you, Sitama.
Thank you.
Yeah,
Thank
you
you.
answered well. Fine. If you answer up to this part, your operative part is through. No problem.
Okay.
Okay.
Thank you.
Oh, someone has asked when to remove the FJ tube.
When to remove the FJ tube?
Yes. Here's a doubt. When to remove the FJ tube? If you do FJ for some other reason.
I mean, in a benign condition, it is expected that the patient will be taking normal diet soon.
Yeah.
Right? Okay. Before normal diet, you will obviously start off with clear fluids and liquids. And when you are starting with clear fluids and liquids, you make sure that in case you have used a Riles tube for an FJ tube, it's okay. If you have used a Foley's catheter for FJ tube, you make sure that the balloon is collapsed. Otherwise, this food will not go in, right? And when the patient is taking clear fluids and liquid by mouth without any hindrance, this is the time when you can remove the tube you have used.
And we want to ensure that a track is formed. It's usually waiting about 2 weeks when the track forms, so that once you remove the tube, there is no spillage interperitoneally. A track should form, which collapses afterwards. In delayed gastric motility, somebody is asking, delayed gastric, wait and watch is a policy. You maintain nutrition, you maintain fluid electrolyte balance, and in some cases you can use some prokinetic drugs like levosulfide, metoclopramide, or some antibiotics like erythromycin, which hastens gastric peristalsis.
And the nasogastric tube should be in place till the gastroparesis problem is completely resolved. Really,
yes.
Don't remove the tube.
Yeah, don't allow stomach to remain distended.
Yes.
Okay. Thank you very much.
Okay. Thank you.
Thank you.